on malnutrition. Okay, can you also see my slide?
Yes po, Doc.
Okay, so childhood obesity, okay, this affects all cultures and all social classes, okay, even those in the higher socioeconomic status with access to, with more access to food, okay, and there are about what, of the 43 million children who are overweight or obese, okay, about 35 million live in developing countries, okay? So that's almost 70%, okay? 70 to 75%, they are living in developing countries. And remember that this is also a form of malnutrition, okay? We have the extremes of malnutrition, the undernourished and the overweight and obese. So while in the US, okay, about 12 million children and adolescents are either overweight or obese, okay? And these are at high risk of non-infectious, adult conditions like hypertension and diabetes, okay? So that's one area where you would expect many patients, okay, endocrinology, okay? So obesity is what? It's the result of a complex interplay, okay? Not just about what children eat, but also about their environment, okay? Their physical activity, plus the genetic predisposition, okay? And so it's a complex interplay of a lot of factors, okay? And it affects all of the pediatric populations, okay, from infancy to late adolescent period. Similar sex are affected, okay? And some would be more in a particular race, okay? So we define overweight, okay, based on the BMI for age Z-score, okay, which is greater than +1, okay? I think the line here should be a little higher. Okay, that's probably for overweight. Okay, and then your obese children are those with Z-score of greater than +2. Okay, so these are your overweight based on the Z-score. So this is based on age and sex because you have different growth charts for females and for males. While obese are those with a Z-score of greater than +2, okay? So a Z-score of +2 is still overweight. Obese is greater than +2, okay? And we have morbidly obese children, okay? Based on the BMI of greater than the 99th percentile for adolescents. And for adults, there is this particular range of BMI, okay, that would classify them into being morbidly obese. So as Asians, we would like to aim for a BMI between 18.5 to 24.9, okay? Because at 25, that's already a classification of being overweight. And 30, a classification of obese. And this is the other definition of severe obesity and morbidly obese adolescents, okay? Although in adults, it's not really the BMI because the BMI is the weight of the body, including the muscles, the bones, and the fats. So it does not distinguish what percentage of that weight is due to fats. Okay, so in adults, they more on focus on waist to hip ratio, okay, or the waistline, okay, to better classify fat deposition. So let's look at the prevalence of overweight and obesity in children. Okay. So as of 2012, okay, the burden of obesity is shifting to developing countries. As I have presented in my first slide, about more than 80% are from developing countries. So we are now seeing what? A coexistence of undernutrition and overnutrition, which are both classifications of malnutrition. Okay. So this is now what we call the double burden of malnutrition. Okay. Double burden of malnutrition. We both have the underweight and the overweight and the obese. So the prevalence of malnutrition under 5, okay, in this age group, we have what? Look at the underweight, almost 20%. So 1 out of 5 children less than 5 years of age is underweight. 1 out of 3, you have a 28.8%, almost 30%. So 1 out of 3 is stunted. And that's a very high prevalence, okay? Now for the overweight, it's about 2.9%, okay? But if you look at the actual number, this could be millions, okay? So the overall prevalence of overweight for children under 5 years of age was, as shown earlier, was about 3% in 2019, okay? In the 0 to 5 months old, okay? Here, 0 to 5 months old. Okay, it still tops what? The age group of overweight. Okay, followed by the 3 to 4 years of age. Okay, so there was a decrease in the overweight from 2018 to 2019. We see the blue and green. We have decreasing in the past in most of the age groups, okay, except for this 24 to 35 months, mostly decreasing, okay? Perhaps due to calamities, okay? Eruption of the volcano, okay, and other threats to food securities in some areas. So for children under 5 years of age, okay, let's look at the prevalence of overweight for length is greater where? Among boys, okay? Greater in boys, in those living in urban areas, and among the richest. So our cousins, our siblings, if they qualify here, living in the urban area, males, among the richest, well, they are the ones at highest risk for being overweight. For 9 to 10 years old, it's quite high, okay? 10%. This is quite high already. 1 out of 10, 5 to 10 years of age, school-age children is overweight or obese. So boys tend to be more overweight or obese than girls, okay? So that's the sex preponderance. Again, more living in urban areas and among the richest. The same for less than 5 and 5 to 10. So for children 0 to 10 years old, these are where we see more cases of overweight and obese. Males in urban areas and in the higher socioeconomic strata. So let's look at adolescents, okay? Up to 19 years of age, okay? About the same for 5 to 10, about 10%, okay? So what is the problem with this one is the sequela, okay? Because 1/3 of these overweight or obese children or adolescents will eventually become obese when they become adults, okay? So that's a risk factor, okay? About 30 to 50% risk of being obese adults. So we need to intervene early at this point, okay? So there was a decrease of overweight for length among urban population, while the rest of the parameters with only small or non-significant decreases, okay? A slight decrease still, okay? But this is pre-pandemic, okay? We do not have the data yet during the pandemic where physical activity has been greatly affected, okay? As well as food, okay? So only among the poor and the middle class where there was a decrease in the cases of overweight, okay? But again, this is pre-pandemic, okay? So why are we concerned with our overweight and obese children and adolescents, okay? It increases the risk for insulin resistance, okay? Hence hyperinsulinemia, and we have the metabolic syndrome consequence. Okay, these are your non-infectious adult conditions that also increase their risk of mortality. Okay, these are all morbidities. Okay, and this may arise as early as they are children or adolescents because of that risk factor of being overweight or obese. And with the onset of metabolic syndrome, all systems are involved. Okay, and therefore you have high morbidities for these cases. So what causes obesity? Okay, let me look at several risk factors because we cannot just attribute it to one, okay, and put the blame on the parents when there could be some genetic predisposition, okay, that needs intervention, medical or drug therapy. Let's look at the energy balance, okay? So to maintain optimum body weight and metabolic status, one should have equal energy intake and expenditure, okay? How do we use our energy? Through exercise, and we have energy intake through food, and there should be a balance, okay, to achieve a normal weight. So obesity and its metabolic complications happen when there is imbalance of energy favoring increased intake. Okay, so being less active, okay, eating more, okay, so ending up with being obese or overweight and later on with metabolic syndrome. So as food enters the gastrointestinal tract, okay, so there is stimulation of inhibitory compounds, okay, leading to release of ghrelin, okay. So this is the hunger hormone, but if you start eating, it has to be inhibited, okay. So once it's inhibited, then everything follows, and then there is satiety. And supposed to be food intake should cease. But we have personal experiences as well, and maybe due to stress or some factors, we just keep on eating sometimes, even if we feel full, okay? Maybe while watching So for the transition phase, outpatient, okay? May last a few days, okay? And once in the transition phase, it's not a guarantee that they will proceed to the next phase. There might be criteria that will require patient to be brought back to the acute phase management. Okay? Meaning to say they fail to respond during this phase. Okay? You see the child will also smile at this stage. Okay? This is a very good clinical find, aside from reduction in edema and appetite improvement. This is an example of your RUTF ready-to-use therapeutic formula. It's ready to use. No need to add water. No need to refrigerate. Remember, these are coming from low socioeconomic status. They do not have refrigerator. They have problems with safe water. They have problems with hygiene. So it has to be a food that is ready to use. Okay. Again, examples of how to prepare F10, F100 at home. So when do we move them back to the acute phase? Okay, these are the manifestations: hepatomegaly, achypnea, weight gain of more than 10 gram per kilogram per day. So a 10-kilogram child will have a maximum weight gain of 100 grams per day. Okay. Okay, so these are observed. And again, just having an incapable caretaker will warrant inpatient management during the recovery phase. Okay. So breastfeeding must be continued. Okay. We have a maximum limit of intake, and we now start to add the nutrients like iron. Okay. This is the frequency of monitoring and what should be monitored during the surveillance period or phase 2. And we now start giving other treatments. Vitamin A, we start to immunize, catch up immunization, the warning. Okay? So it's a holistic approach in the management. And these are the recommendations for transfer to outpatient therapeutic care. Okay, I leave you responsible for this one. And the discharge criteria. The MUWAC must be at least 12.5 centimeters for 2 visits. No edema for 10 days and clinically well. And the other criteria for this age group. Okay. And also for much younger infants. Okay. Then there is transition to acute phase again. If you have these manifestations, okay, which are self-explanatory, okay, these are signs of progression and not improvement. So refeeding syndrome is overfeeding, especially when they start to have better appetite and the caregiver is so eager to achieve a better weight, but again, there could be a syndrome of refeeding one, okay, refeeding syndrome. And it could also be associated with electrolyte imbalances. So we limit the intake, never force feed, sometimes fasting for 1 day. And hence, once with refeeding syndrome, we go back to the acute phase, okay? And we don't start with what is recommended, but with only 50% of the recommended intake, okay? And we check for electrolytes. So failure to respond to treatment are the following. And until when do we observe them to consider failure? Okay, if does not improve in 4 days, if edema is still present in 10 days, okay, if there is clinical deterioration at any time, these are failure to respond to treatment. And we investigate, there could be co-infections, okay? There could be a caregiver concern. The patient is on medications, could be side effects of the drugs, okay? And all other aspects have to be addressed. And we further investigate. Initially, we do workup, blood, chest x-ray, CSF if necessary, okay? And then the rest will be computation for catch-up as part of nutrition build-up. We are aware of the proportion of macronutrients, which will be the basis for the computation of nutrient intake. And it is age and sex dependent. And you just have to memorize this one. For the catch-up calorie or protein requirement, what you will need is the actual body weight of the child, and you can compute for the ideal body weight. We have the requirement that is there for weight age. This is the same formula for catch-up calories or for protein. So, if a 3-year-old girl was admitted, this is the actual weight of 9 kilograms. How do you compute for it? 3-year-old girl, okay, there it should be here at 3 to 5, okay, around 920 or 1260 because it's a female. That's the energy kilocalorie requirement. And we compute for her ideal body weight of 14 kilograms. So the 920 came from the table times ideal body weight over actual weight. And this is the caloric requirement daily. Okay. And for the protein catch-up, what is the requirement for age of protein is 17. Okay, let's say the child is 3 years old, about 3. Okay, you put here the grams per day, ideal is computed, actual is given. So this is per day. Okay, grams of protein, convert grams to calories, 4 kilocalories for every gram of protein. And now you can deduct the actual caloric intake minus the protein requirement. What is left will be divided into carbohydrates and fats. And we start with 50% of computed caloric requirement and advance it daily until daily requirement is met. And that's how we order it in the chart together with the other nutrients. Zinc, folic acid, vitamin A, iron will also be part here. So thank you for listening. Okay, I think the slides will be shared with you as well. Thank you, everyone. You can now have your break.
Thank you po, Doc.